intraperitoneal chemo has been investigated in multiple trials over the last 20 years. Back into the mid-90s, we were investigating this before taxanes. And people were really excited about it because it made sense, delivering the chemo both intravenously and in the belly cavity where the tumors are was thought to enhance your treatment effects. Not without increased toxicity, but manageable toxicity. Most trials have shown a survival benefit, and people were very excited after GOG 172 was published and showed a significant survival advantage for intraperitoneal administration. But it's a difficult regimen to get, and people have a hard time with the full doses of it. Only 40% of patients in that trial were able to get the full 6 cycles of their intraperitoneal regimen. And that made it hard, so people dropped the dose. They improved their supportive care, and some people could still get it, but it was hard to give. One of the questions that it raised was the intraperitoneal arms in a lot of those trials actually were getting more chemo over the 3-week period than patients in the control arm getting Q3-week chemo. And so that raised the question as to whether this was intraperitoneal administration or was this dose density. And that's when the dose dense trials came out. The dose dense trial in Japan showed a significant survival advantage as well, which was very exciting. We wanted to replicate that in the United States, and we undertook GOG 262 to try to confirm those results. Unfortunately, there was no survival benefit. The survivals were equivalent. Now that trial was a little bit limited due to the co-administration of bevacizumab in an uncontrolled fashion. When we take that out and look at the patients that just got chemo without bevacizumab, those survival curves start separating. And so would we have gotten a survival benefit without bev? We may have, but we won't know. Both dose dense and intraperitoneal are a little bit harder to tolerate. They both seem to help compared to Q3 week, but are probably not for everybody. And which one you prefer oftentimes depends on your own personal bias.